Good morning, everyone. Today we are having a presentation of management of acute endophthalmitis after cataract surgery by Dr. Aisha Meleh. She's a senior registrar at National Eye Center, Kaduna. We'll be looking forward to your meaningful contributions and your questions. Thank you. Dr. Aisha, you can start.
Okay. Thank you very much. Good morning, everyone. I'm Dr. Aisha, and this morning I'll be presenting.
Hello, Dr. Aisha, can you hear me?
Yes, I can.
Yes, we can hear her.
Okay. Yeah. Can I start?
Please go ahead.
Okay. Good morning, everyone, senior colleagues, consultants, and colleagues. This morning I'll be presenting management of acute endophthalmitis after cataract surgery. I'll be presenting it based on the outline written here.
Can anybody else hear me?
Yes, we can hear Dr. Aisha. We can as well hear you.
Okay.
So my presentation will follow this outline. I'll start with the introduction through the incidence, pathogenesis, the management, prevention, then I'll conclude. The term endophthalmitis is used to describe intraocular infection due to bacteria or fungi that involves the vitreous and or the aqueous. Once you have inflammation, non-infectious inflammation involving the vitreous and aqueous is known as uveitis, but the term used for the infectious one is endophthalmitis. And endophthalmitis is broadly divided into post-operative endophthalmitis, which could be acute or delayed onset post-operative endophthalmitis. There's post-traumatic endophthalmitis, which follows trauma. There's endophthalmitis, post-intravitreal injection endophthalmitis that follows intravitreal injection. There's bleb-associated endophthalmitis, and then endogenous endophthalmitis. These four types are exogenous, meaning the offending organisms come from outside, while the endogenous is usually from endogenous spread, either from sepsis. There's a focus internally. Acute onset post-operative endophthalmitis is defined as endophthalmitis occurring within 6 weeks of surgery. Usually the most common the most common cause is cataract surgery. Majority of cases follow cataract surgery. Endophthalmitis is a rare complication of cataract surgery, but it's really a dreaded complication because it's associated with a lot of morbidities, including decreased vision and even blindness. It requires prompt diagnosis and treatment to salvage vision and have good outcomes. Several studies have reported different incidents of endophthalmitis worldwide, but what is known is that the incidence is reducing compared to in the past because of certain preventive measures that are being taken, which I will discuss later. But the reported incidence in most studies it ranges between 0.03 to 0.2%. There are several risk factors, and these include preoperative risk factors like patients with diabetes mellitus. Patients with diabetes mellitus usually have lazy leukocyte syndrome. They have increased predisposition to infections. Same thing with older patients, patients with untreated blepharitis. Patients with untreated dicrocystis are also at risk of post-op endophthalmitis. Patients with prosthesis in the fellow eye, especially if it's infected and not treated, And then patients with active systemic infections. These are the preoperative risk factors that need to be taken care of before cataract surgery. Then there are intraoperative factors too that can predispose patients to endophthalmitis, and these include inadequate preparation, as in failure to use topical povidone in its correct concentration. Usually 10% povidone iodine should be used to clean the skin, and then 5% for the conjunctiva. And then prolonged surgery time is also a predisposing factor. Intraoperative complications like posterior capsule rupture and vitreous loss. Some studies have shown that sutureless clear corneal incisions also increase risk of post-op endophthalmitis, and then temporal incisions too. Then post-operative risk factors include delay in starting post-op antibiotics, because some studies have shown that after cataract surgeries, aqueous samples usually show subclinical bacterial isolates, but so most of those patients usually don't come down with endophthalmitis because the host immune system clears them, and also starting antibiotics on time. So delay in starting post-op antibiotics also increases the risk. And then post-operative wound leak, especially if not closed early, and then use of contaminated eye drops. For the pathogenesis of endophthalmitis, different organisms cause endophthalmitis, but mostly bacterial organisms, and mostly they are gram-positive bacteria, and then some fungal elements too have been identified. So the pathogenesis of endophthalmitis is from synthesis of certain factors by the offending organisms, which cause damage to tissue, and also the immunity that the host mounts to fight this infection also adds to the damage to tissues. The commonest organism isolated from post-op endophthalmitis is coagulase negative staphylococcus, and these organisms they have, especially Staph epidermidis, it has ability to form biofilms, which helps to protect it from host immune system and even antibiotics. And then Staph aureus has cell surface proteins, adhesin, and also secretes toxins that help it in its pathogenesis. And that's why Staph aureus usually causes more damage than Staph epidermidis, which doesn't have toxin. It doesn't produce toxins. And then others are Streptococcus, Staph viridans, Staph pneumoniae. They also cause tissue damage, usually associated with worse prognosis because of the toxins they produce, autolysin, hemolysin, and so on. So now the management of post-op endophthalmitis endophthalmitis is an emergency. So usually management will start by taking history, examination, and then so on. So patients with endophthalmitis, post-op endophthalmitis usually present with acute onset of decreased vision, redness, discharge, eye pain, and eye swelling, usually from the second day to the 6th day post-op, but it could be within the first 6 weeks post-op. Most studies have shown that, especially for patients in the endophthalmitis vitrectomy study, most of the patients presented within the first week post-operative. And then on examination, you will find reduced visual acuity to a variable extent from light perception, and it could be anything up to light perception. And then they usually come with lid swelling, conjunctival injection, chemosis, corneal edema, and then hypopion in the anterior chamber with inflammatory infiltrates, even fibrin membrane. There may be plaques inside the capsular bag. And then one classic sign is loss of red reflex and infiltrates in the vitreous, which may preclude view of the retina. if it's intense. These are an image showing clinical signs of a patient that presented with endophthalmitis. There's conjunctival injection, there's hypopion with corneal edema, and reduced red reflex. This picture is showing same picture. There's hypopion, conjunctival injection, corneal edema, fibrin membrane. This is also showing intense inflammation with formation of fibrin membrane. And this image is showing vitritis in a patient with post-op endophthalmitis. Same picture here, endophthalmitis with hypopion injection. So endophthalmitis is not always when you see inflammation post-op that it's endophthalmitis. Certain differential diagnosis must be ruled out. One of the most important differential is toxic anterior segment syndrome, TAS. Others are flare-up of pre-existing uveitis, retained lens material, chronic vitreous hemorrhage, retinoblastoma in children, retained triamcinolone acetonide, and viral retinitis. For toxic anterior segment syndrome, I'll use this image to differentiate them. The image on the left is an image of a patient's eye with toxic anterior segment syndrome. For patients in toxic anterior segment syndrome, patients usually present within the first 24 hours of surgery. Meanwhile, in post-op endophthalmitis, usually after 24-48 hours. They present with reduced vision too, just as in endophthalmitis. But pain is not as marked as it is in endophthalmitis. And then the visual acuity too is reduced to a variable extent. And then on examination, patients with toxic anterior segment syndrome present with corneal edema, limbus to limbus corneal edema. Patients with endophthalmitis too do have corneal edema, but usually not as marked as that in TAS, because the corneal edema from TAS is usually from effect of toxins on the endothelium. And then in toxic anterior segment syndrome, they could present with hypopion too and anterior chamber cellular infiltrates, just as in endophthalmitis. One of the important distinguishing features is that in TAS, there's no vitritis, while in endophthalmitis, there's vitritis. And this may be confirmed with ultrasound scanned imaging too. So for the second differential, which is retained lens material, the image on the left is showing an eye with retained lens material. It may mimic endophthalmitis because the presence of retained lens material could incite inflammation and cause uveitis and even vitritis, depending on how big or what lens material is left, and if it's in the vitreous, like in this ultrasound image that has shown probably the patient had lens drop intra-op. So, but it's usually difficult to distinguish this from endophthalmitis, and then a vitreous type may be necessary for culture. But in retained lens material, the inflammation may reduce with use of steroids. And then another differential is uveitis, exacerbation of a pre-existing uveitis. A patient with posterior uveitis having an exacerbation may mimic endophthalmitis. But when you examine, you may be able to see the retinal lesion, like in this image of a patient with a previous toggle scar having a reactivation. And then chronic vitreous hemorrhage, especially when there's depigmentation of the red blood cells, may look like vitritis and mimic endophthalmitis. But another distinguishing feature is that patients with endophthalmitis usually come with other signs of inflammation, but for those with vitreous hemorrhage, the eyes are usually relatively quiet. For retained triamcinolone acetone, after patients that have had intravitreal injection of triamcinolone may have the precipitates or debris in the anterior chamber that can settle and look like hypopion, mimicking endophthalmitis. But however, history of that injection and other signs may be a distinguishing feature. For investigations, mainly endophthalmitis is diagnosed clinically, or you may need some investigations to help confirm the diagnosis, like a B-scan, ultrasonography. Sometimes there may be corneal edema or marked vitritis that precludes a view of the posterior segment. So you may need an ultrasound scan, which will help you exclude retinal detachment and also show vitreous opacities that may be in keeping with the vitritis. And then the most important one is a vitreous and aqueous tab for microscopic culture and sensitivity. It's important because it will help you to confirm your diagnosis. It will help you in assessing antibiotic susceptibility. And also, in case you start with your empirical treatment and you're not getting response, your MCS result will guide you in further treatment. You take samples and make smears for gram stain, which will help you to know if it's gram-positive or gram-negative organisms or both are causing the infection. And then you take samples also for culture on blood agar, chocolate agar, Sabrot's agar, and thioglycolate. But this will help to culture most of the organisms that have been isolated before. Now, this is a flow chart showing, it's just a small guide what needs to be done. Because we are taking both aqueous and vitreous sample, so it's the same thing for the vitreous sample. When you take the sample, you put a drop for gram stain, and then the remaining for culture on chocolate agar, blood agar, and the others like I mentioned. So how do we do the vitreous tab? The taking vitreous sample is very important in endophthalmitis. It needs to be done immediately so that treatment can be started. So the first thing is you get your antibiotics, you prepare them, you get all your syringe, all your consumables, and then you prepare the eye by use povidone iodine 10% on the skin, just as you do before cataract surgery, and then 5% in the conjunctiva. Then for the anesthesia, you can give a retrobulbar block, peribulbar block, subtenon block, or even topical anesthesia may be used. And then you use a lid speculum for good exposure. And then you use 23 gauge needle. Well, you can either use an insulin syringe, you can use a 23 or 25 gauge needle mounted on a 2 mil or 5 mil syringe, or as in this picture, butterfly type of needle on a 10 mil syringe. And then for being that is a pseudophakic eye, you use a caliper to measure. It's going to be done through the pars plana, so you use a caliper 3.5 millimeters behind the limbus. Then you use your needle to gain access into the vitreous cavity through the pars plana, with your needle pointing towards the optic nerve head, and then you aspirate about 0.2 to 0.3 or 0.5 mils of vitreous sample, and then you send to the lab. This picture is showing how to use the butterfly type needle attached to a 10 mil syringe. Here, mostly we use insulin syringe. The common organisms that have been cultured from endophthalmitis, according to the endophthalmitis vitrectomy study, are coagulase negative Staphylococcus, 70% of them were there, and then followed by Staphylococcus aureus, Streptococcus species, Enterococcus species, gram negative, other gram negative bacteria, and gram positive. So apart from the microscopic culture and sensitivity, newer investigations are available, like the real-time polymerase chain reaction. This helps in early detection. It's fast, and then it has a high yield. It's very sensitive, because some cultures may be negative but it's still endophthalmitis. But with PCR, it has high sensitivity. Others are the DNA microarray, peptide nucleic acid fluorescent in situ hybridization, and next generation sequencing. All these ones are aimed at enhancing early detection, because early detection and prompt treatment helps in optimizing visual outcome. So after making a diagnosis of endophthalmitis, it's important to start treatment. And the treatment, like I said, is use of broad spectrum antibiotic. And then this is based on recommendation of endophthalmitis vitrectomy study. The endophthalmitis vitrectomy study gives a guide. I use visual acuity to guide you on which modality of treatment to give the patient. For patients with a visual acuity of light perception, the EVS, endophthalmitis vitrectomy study, recommends immediate pars plana vitrectomy with intravitreal antibiotic injection. But for patients with a visual acuity of hand movement or better, they recommend a vitreous tap for the MCS and then intravitreal injection of antibiotics. And the antibiotics they used and recommended are vancomycin, 2 milligrams in 0.1 mil, which covers for gram-positive organisms, and then ceftazidime 2 milligrams in 0.1 mil, which covers for gram-negative organisms. But for patients that have allergy to penicillin-based medications, amikacin can be used 0.4 milligrams in 0.1 mil. For patients with presumed fungal cases, amphotericin B, 0.005 milligrams, 0.1 mil is used, or voriconazole 0.1 milligrams, 0.2 mil. But these antibiotics usually come in vials, in powdered form, and they need to be constituted. So for ceftazidime, how to constitute it is it comes in 250 milligram vial, 500 or 1000 milligram vial, but preferably the 500 milligram ampoule should be used. So when you get your 500 milligram ampoule of ceftazidime, you use water for injection or normal saline to dilute it. For the 500 milligram, you add 10 mils of water for injection, and then you make sure it's well dissolved in it. Then you draw up so when you now dissolve that 500 in 10 mils, it means you have 50 milligrams per mil. You now draw up 1 mil from the ampoule, and then add 1.5 mil of water for injection or normal saline, making it up to 2.5 mils in your syringe. And then from that syringe, you draw up 0.2 mils so that you can discard and get your adequate 0.1 mil. And from that, it means you have in 0.1 mil, you have that 2 milligrams of antibiotic to inject. The same thing is done for vancomycin, but the only difference is water for injection should not be used to constitute vancomycin, normal saline only. And then in case one wants to use amikacin, however, amikacin has been associated with retinal toxicity. So if it's not necessary, one should not use it. It comes as a solution, 500 milligram in 2 mils. So you get a syringe, and then you draw 1 mil from the 2 mil vial. To that 1 mil that you have drawn, that means you have 250 milligrams in it. Then you take, well, you add 1.5 mil of water for injection to that 1 mil of amikacin that you took. After that means you now have 40 milligram in that. You have 40 milligrams in that in that, sorry, you have 250 milligrams of amikacin in that 2.5 mils that you've made in your syringe. So after that, but you want to, the dose of amikacin is 0.4 milligrams per mil. So to achieve that, you take 0.4 mils from that 2.5 mils, and then you make it up to 10 mils with normal saline or water for injection. And then from that, when you draw up 0.1 mil, that 0.1 mil will contain 0.4 milligram of the antibiotic. So that's for the initial treatment. You take your sample, send for MCS, give intravitreal injection, do a pass-planner vitrectomy. Subsequent treatment from the next day, for topical fortified antibiotics can be used 4 to 5 times daily, usually vancomycin 5% and ceftazidime 5% or moxifloxacin. Then some people also use subconjunctival antibiotics, as they can increase the intraocular concentration to bactericidal level and can be sustained for a long duration. And then topical cycloplegic agents, this will prevent against posterior synechia and then also reduce ciliary spasm. Then according to the endophthalmitis vitrectomy study, there was little or no benefit from use of oral or intravenous antibiotics. But however, the thing against this is that the antibiotic they used in the study was ceftazidime and amikacin. And then, but most of the organisms they cultured were gram-positive organisms. And then amikacin has very poor ocular absorption. So recent studies have shown that use of parenteral 4th generation fluoroquinolone like moxifloxacin, oral moxifloxacin 400 milligrams daily for 10 to 14 days is beneficial, or use of clarithromycin twice daily. And some authorities advocate use of corticosteroids. The endophthalmitis vitrectomy study group also used intravitreal corticosteroid, but it showed no benefit. Corticosteroids can be used either systemic, intravitreal, or topical corticosteroids. The rationale behind it is that the corticosteroids will help to reduce the inflammation incited, which is thought to reduce damage to tissues and optimize visual outcome. So these patients need to be followed up closely from the first day after either PPV or intravitreal injection to look out for signs of clinical response. And these signs include, for patients with fibrin membrane, you expect it to start contracting. You expect the cellular activity in the anterior chamber to start reducing, the hypopion level to also start reducing. And then you may also use ultrasound to monitor the changes in the vitreous. But if clinical signs are worsening or not improving after 48 hours of antibiotics, you need to review the sensitivity results, which should be out by then, and then you may modify your antibiotic choice according to the sensitivity result. And for patients that probably had hand movement, vision or better, and you didn't do pass-planner vitrectomy, you may consider doing it after 48 hours if no clinical improvement. And then intravitreal antibiotics can also be repeated after 2 days, but not all facilities have, not all hospitals have facility for pass-planner vitrectomy. And another thing to note is that even for patients that come with a visual acuity of light perception, if you don't have facility for pass-planner vitrectomy or no surgeon nearby, to avoid delay, you may give the intravitreal injections while preparing to send the patient for vitrectomy. This is an image showing a patient that was followed up over 6 weeks. The patient, the first day presented with the hypopion and other signs of endophthalmitis. The visual acuity was hand movement, so intravitreal tap and injection was done. And then you can see by the first day, visual acuity was already improving, hypopion reducing. By the second day, improvement, and by 6 weeks, the vision had improved to 20/20, hypopion disappeared, no injection, no signs of vitritis. Apart from managing index case, in cases of post-op endophthalmitis need to be reported usually to the hospital incidence surveillance team. If they reach, it needs to be reported so that a review can be done, and then the source of infection or whatever risk factors can be identified, which could be from the patient, from the surgeon, or even from the theater, so that you avoid further incidents. So usually the team will re-examine the patient and find out if maybe the patient had those risk factors, pre-operative risk factors I mentioned, maybe they weren't taken care of, or maybe the surgeon wasn't experienced, maybe there was a PC red, vitreous loss, or prolonged surgery time, so this could be tackled. And then other hospital factors like the theater, the autoclave or whatever sterilizing unit was used, the viscoelastics, the saline that was used, the instruments, they need to be cultured and then checked, the gloves, and all the things that were used. You need to know the badge of the consumables used. Complications of endophthalmitis include loss of vision, persistent vitreous opacification even after the infection has been controlled, which may necessitate a vitrectomy. You may have a retinal membrane, chronic uveitis, secondary glaucoma, and even phthisis bulbar. And then complications from treatment, like the PPV, they may come down with microhyphema, wound leak, dislocated intraocular lens, choroidal detachment, retinal tear, corneal edema. Visual outcome after endophthalmitis. Like I said earlier, prompt detection and treatment is required to optimize visual outcome. But despite this, most cases, prognosis is not always good. However, the prognosis depends on the offending organism. For Staphylococcus epidermidis has a better prognosis than infection from Staphylococcus aureus or Streptococcus species. In the endophthalmitis vitrectomy study, only 53% of treated eyes had biennial visual acuity of 612 or better. 15% had visual acuity of 660 or worse. And more recent studies have also shown that 50% of eyes with acute onset post-operative endophthalmitis had a biennial visual acuity of 612 or better, which is comparable to the endophthalmitis vitrectomy finding. An important predictor of visual outcome, like I said, is the infecting organism, and the others are prompt and appropriate treatment, and then the presenting visual acuity. Patients that present with worse visual acuity usually have a worse visual outcome than those with a better visual acuity. So prevention is the key. To prevent endophthalmitis is better than to treat it. So for the prevention has to start at various stages from the theater. The theater preparation, we should include strict theater discipline, maintaining sterile areas, avoid contamination, avoid overcrowding the theater, separating clean linens, clean instruments from dirty ones. And then perioperative prevention of like treatment of any pre-existing infections like brepharitis, conjunctivitis, dacryocystitis, and infection of the contralateral socket. There should also be scrupulous preparation of surgical site, with 5% povidone iodine in the conjunctival sac, 10% on the skin, and then adequate dripping. The eyelash should also be dripped. Use of povidone iodine, several studies have shown its benefits. It significantly reduces incidence of post-op endophthalmitis. A prospective randomized trial of 131 eyes undergoing intravitreal injection showed that with at least 30 seconds of exposure to 5% povidone iodine in the conjunctiva, colony forming units of conjunctival bacteria decreased significantly. So this goes a long way in reducing the risk of post-op endophthalmitis. This is an image showing how to prepare the skin. I've been mentioning you put 10% on the skin, 5% in the conjunctival sac. It should ideally be left for at least 3 minutes before washing. And then excellent wound construction and good wound closure also goes a long way in reducing the risk. Avoidance of serious intraoperative complications like posterior capsule rupture, prolonged surgery time. And then use of antibiotics too, perioperative use of antibiotics, like use of intracameral antibiotics. The European Society of Cataract Surgery performed a randomized control trial and reported that intracameral cefuroxime during fecal emulsification reduced the incidence of post-op endophthalmitis by approximately 5-fold. However, this is not used by all authorities. Some studies showed no benefit from it, like the endophthalmitis. Okay. Yeah, some studies showed no benefit, so it's not practiced everywhere. Then prophylactic use of subconjunctival antibiotics too, also controversial. Some studies showed benefits, some did not. A series of consecutive 13,806 consecutive cataract surgeries reported that subconjunctival antibiotics were associated with a significantly reduced rate of acute onset postoperative endophthalmitis. Some add antibiotics to irrigation solution, but it's also controversial, as the endophthalmitis vitrectomy study showed that some patients were given antibiotics in the irrigation fluid, and still 11.5% of those same patients had endophthalmitis. So there was no significant benefit. And then use of prophylactic oral antibiotics too, like fluoroquinolones. And then topical fluoroquinolones too, 1 to 2 or up to even 3 days before surgery. But there's no evidence of its benefit. In conclusion, acute onset postoperative endophthalmitis is an uncommon but serious complication of cataract surgery. If EVS provided valuable guidelines for the diagnosis and management of this disease and is still beneficial till today. Treatment outcomes may be poor even with prompt and appropriate treatment. Therefore, prevention is very important. Topical perioperative povidone iodine is a well-established and important step in this prevention. My references. Thank you.
Thank you, Dr. Aisha, for this eloquent and elaborate lecture on management of acute endophthalmitis, acute postoperative endophthalmitis. We have a few questions here. We have 2 questions, actually. The first question is, you have shown mastery of the subject. Please, why can't we use water for injection for vancomycin? I have once had an experience of a terrible mixture after adding normal saline to ceftazidime. I wrote a note to the pharmacist who informed us that we used the wrong solution. So his question is, why can't we use water for injection for vancomycin?
Okay.
Okay, should I go to the next question?
Yes.
Okay. The next question is, did you say TAS presents within 24 hours and after 24 hours to 48 hours for endophthalmitis post-operative? That's the second question.
Oh, okay, should I answer? Yeah.
Okay, there's a third and fourth questions. Maybe you should answer the first two, then I will ask the second and the third and fourth questions.
Okay. For the first question, why can't we use water for injection to constitute vancomycin? I really don't know the answer to that. Maybe someone can help me. I don't know. And then for TAS, what I said is that TAS usually presents early. Most cases present within the first 24 hours post-op. Some have even reported within hours post-op. While for endophthalmitis, most studies showed that they present by the second day post-operative onwards. But it's not a hard and fast rule. I don't know if anyone has a better explanation.
Okay, I remember hear you saying, you said in the endophthalmitis vitrectomy study, most of them presented within the first week. I think you even mentioned a percentage.
Yes.
Within the first 7 days.
Yeah.
So it's basically usually within the first 7 days, endophthalmitis, but most commonly by 48 hours, but anytime post-operatively, it can occur. So far, it is within the first 6 weeks. That is acute post-operative endophthalmitis. Another question is, thank you so much, Ma. Can you go over the constitution of amikacin for intravitreal injection?
Okay.
Okay, this one too has to do with that. Can you go over the present through reconstitution of ceftazidime and amikacin and dilute for the intracameral injection? Intracameral injection. Is this the medication they want?
Okay. Okay. So for the amikacin, I said it comes as a solution, 2 mils, 500 milligrams in 2 mils. So what is written on my slide is 2.5 mil syringe. I don't know about any 2.5 mil syringe. So to be practical, like a 5 mil syringe. So you take 1 mil of the amikacin from the 2 mil solution. And then you add 1.5 mil of water for injection. That makes it 2.5 mils, right? So from that 2.5 mils that we've constituted, take 0.4 mil of the solution in a 10 mil syringe. And then you add, since you've taken 0.4 mils, that means you add like 9.6 mils of this water for injection to make it 10 mils. And that will now make it 4 milligrams in each mil. And you want to inject 0.4 milligrams. So from that 4 milligram per mil, if you take 0.1 mil, it gives you 0.4 milligrams. I don't know if I'm clear. And then for the ceftazidime, when you have a 500 milligram ampoule, you dilute it with 10 mils of water for injection or normal saline, dilute it well, and then you take 1 mil of it. That 1 mil is now containing 50 milligrams. Since once you add 10 mils to 500 milligrams, each mil will contain 50 milligrams. So you take 1 mil and then you add 1 mil, 1.5 mil of water for injection or saline to it, making it up to 2.5 mils. So from that 2.5 mils, why you now drop, you can just drop the 0.1 mil, or why they said 0.2 mil is so that you can, some will remain in the syringe and then you can draw it and discard some so that you can get the 0.1 mil, which will contain 2 milligrams of the antibiotic. And it's the same thing for the vancomycin. This is from Kansky. There are some places I saw that they give 2.25 milligrams of the ceftazidime. I don't know about that. Thank you.
Okay, thank you. This one is